Okay. First, I would like to thank again the AfriCardio and the Israel Heart Society for this invitation. It's always a pleasure for me. We will go back mainly to physiology in my talk. I'm mostly a cardiologist, not a sports cardiology specialist. But every time a lot of people ask me, explain us how to interpret a cardiopulmonary exercise testing, because we don't understand a lot of things in the report. So I will try with you to share during the last 20 minutes what we have to know from a cardiopulmonary exercise test, either performed in young ladies like this. François Carré does this kind of test. I used to see more generally this kind of patient, unfortunately. So a cardiologist perform an exercise test, and they believe in general that the heart is everything. We don't have to forget that during a test, we have to mobilize the whole system, the lung, the suprapulmonary circulation, the vascular peripheral circulation, the muscle metabolism, in order to transport oxygen from outside to the exercising muscle, and to remove CO2 from the muscle after exercise under a correct blood pressure to the special organs, the heart and the brain. And you see that the heart is only one of the parts of the response. That's to say that when you have a decrease in exercise capacity, obviously it can be caused by the heart, but it can be caused also by anemia, by vascular disease in the periphery, by abnormality in the peripheral circulation, but also from problem raising from the lung or from the periphery, obesity, myopathies related to statin and to other drugs, for example. I will ask you only to remember only one equation from physiology, the Fick equation. Some of my students do not know exactly this equation. This equation is fundamental to understand cardiopulmonary exercise testing. This equation states that every time at rest and during exercise, the oxygen consumption of the body of an organ is the product of the local or the global cardiac output by the arteriovenous oxygen difference. So, when you are at rest, you have VO2 here, which is the product of cardiac output by arteriovenous difference. And when you perform a graded exercise, you will increase cardiac output. You will extract more oxygen until a fixed level, and you will reach a maximum value of the exercise, which is what we call the maximal oxygen consumption, the famous VO2 max. Nearly, for example, this is a slide that I made about 30 years ago now, when we performed a Swan-Ganz catheter during this exercise in patients with heart failure. You see here the evolution of the VO2 and VCO2 in white, and you see the evolution of the cardiac output measured by the Swan-Ganz catheter and the evolution of the arteriovenous oxygen difference. See how closely the cardiac output and the VO2 behave during exercise. Clearly, when you follow the evolution of the VO2, you have a mirror of the evolution of the cardiac output. So VO2 max is the maximal value of oxygen that it transports, diffused, and used by the tissue, and it corresponds to a plateau at the end of exercise. You cannot prolong the exercise. You have hit a plateau, and it corresponds to an exclusive anaerobiosis during exercise. So these are some values to retain. In normal values in a 30 years old man, you have at rest a cardiac output of 6 liters. You have an AVO2 difference of 4. This result in 240 milliliters of oxygen per minute, which is about 3.5 ml per minute per kilogram of VO2. You have to remember this. During a normal effort, you increase, for example, cardiac output to 18, you extract more oxygen, and you reach 17 of peak AVO2 difference. This reach 3 liters of VO2 of maximum, which is about 40 ml per minute per kilogram. And if you are an athlete, you can increase much more the cardiac output. You can slightly extract more oxygen, and you reach very high values of VO2, as you see here. And if you take, for example, EPO, you can largely increase the arteriovenous oxygen difference without a change in cardiac output, and you can reach very fantastic values that are not seen in normal subjects. This value decreases logically and linearly with age. On the contrary, they increase with training, and with training, you can increase this value by about 30 to 40%. This is an example of an athlete. For example, you have 2 minutes of rest, then it's graded exercise, workload increases, you have in green the increase in VO2, then you have the predicted value, and at the end you have a splendid plateau. You see, VO2 cannot increase, the patient has to stop. And the patient is very fit because he reached 150% of the predicted value. This is the French athlete VO2 max 10 years ago. You can see that the higher values are observed in subject performing marathon, but only if you play football, which is not a very intelligent sport, you see. You have to have 60 ml of per minute per kilogram of VO2 in order to play the Olympic Games. And for example, my co-chairman is probably here. One of my colleagues from Africardio in the last row is here, and probably that the president of the Africardio will be here. I have to test him. So there are some questions you have to ask to you or to the doctor performing the test before interpreting the cardiopulmonary exercise test. Was the test conducted on treadmill or on bicycle? Because the peak VO2 is about 10% higher on treadmill. Which protocol? Was it a graded exercise or a constant workload exercise? What were the work rates? What were the stages? You have to know the gender, the body weight, the age, the fitness level, in order to know the normal predicted values, which are numerous. There are various different normal values according to Wasserman, Jones, and so on. And finally, you have to know, it's very important, if exercise was really conducted until maximum to interpret the test. So this is very difficult. In athletes or in normal subjects, you may find a plateau of VO2 max. In patients, it's very difficult to obtain this, and you have to rely on the criteria. Has he reached the maximal predicted heart rate? Has he reached a respiratory exchange ratio, which is the ratio of VCO2 by VO2 greater than 1.10, 1.20? Was the ventilatory threshold, I will explain you later, largely surpassed? These are criteria that suggest you that the exercise was really conducted until the maximum. If you are not here, you are not sure that the test was conducted until maximum. And if the test was not maximal, you have to know why the test was stopped. Now, some slide about physiology. When you make a graded exercise test here, what occurs? You increase the work rate, you see VO2 increases, the reject of CO2 will increase, heart rate will increase, ventilation will increase, you are in the aerobic phase, so you don't have any change in lactate in pH. Then, at a certain level of exercise, you will see that plasma lactate will slightly increase in plasma. You have started entering a phase which is in part anaerobic. And lactate increase, but pH do not change. Why? Because the lactate and the H+ are buffered by bicarbonate, dissociating in water and in CO2, and this creates an increase in the CO2 rejected, an increase in ventilation to reject the CO2, but pH doesn't change. And if you continue to exercise, you see here that at a certain level, pH decreases because the increase in lactate is so high that buffering by bicarbonate is not enough, and you have a decrease in pH, and at the end, you reach the VO2 max of the patient. This is very important value. The first threshold, general, occurs at about 50 to 60% of the maximum VO2. The second threshold occurs at about 80%. If a patient stops exercising without reaching the first ventilatory threshold, probably the exercise test was not maximal or was stopped for a reason other than cardiologic. If you don't measure gas exchange, you don't have this information. For sport cardiology, it's very interesting because the patient has often, what is my training level? Well, you say you can train between this and this. If you are an athlete, you can train at this level. If you are a patient, we propose cardiac rehabilitation at this level of exercise. So clearly, you have very interesting metabolic parameter to guide the exercise or the training program in this patient. Okay? So what are the values of this kind of test in cardiology? First, for fitness evaluation, it allows determination of the VO2 max, the determination of the threshold for prescribing exercise, and you follow the effect of training. You have to increase VO2 by 20 to 40%. For example, if a patient after a training program in my department do not increase his VO2 by more than 10 to 20%, I know that he was not compliant or that the training level was not high enough. A lot of people say we don't have to measure peak VO2. We have the value of rest, of ejection fraction, and so on. There is absolutely, for example, in heart failure, in this study of more than 150 patients with ejection fraction less than 45%, you can see there is no relationship between ejection fraction and peak VO2. For example, if you take here the patient with the ejection fraction of 10%, peak VO2 can range from 7 to about 25 ml per minute per kilogram. There was a talk of Alec Vanian yesterday about valvular disease. The same applies, for example, for valvular disease. There is no relationship between the mitral valve area and the peak VO2 in this patient with valvular disease. And very important to understand, it is really impossible without measuring gas exchange to diagnose the cause of exercise limitation. If you have a reduction in peak work rate or in peak VO2, is it related to cardiac disease, a pulmonary disease, or pulmonary motivation? Well, you can rely on this parameter. First, was the ventilatory threshold? If it is achieved and normal, you can say the test was valid. If the ventilatory threshold was not reached, the test is either submaximal or the patient stopped because of, for example, pulmonary disease. These are two examples of the curves, VO2 with CO2. There was no increase in the VCO2 curve. The patient stopped before what we call the ventilatory threshold. These patients because of obesity and pulmonary disease and not because of cardiac problem. Second, you can rely also on the respiratory exchange ratio. That has to be very high. You can rely on the percentage of maximum predicted heart rate reached. And you can also see the VO2 recovery, which was not generally assessed during a study because we stop in general measurement at the end of exercise. It's very interesting to prolong the measurement because we see the kinetics of recovery. In an athlete, you see the VO2 decreases very, very rapidly. By chance, remember, the people say, I perform exercise echocardiography after the test during recovery. You understand that the echo made here had nothing to do with the echo made here. It's only after 30 seconds, you see. And the kinetics of recovery is much prolonged when you have a cardiac disease, while it is very rapid in normal subjects. So if you have a patient, you suspect a submaximal exercise, you look at the kinetics of recovery. If it is normal, the subject is normal and exercise was probably submaximal. If it is slowed, the patient probably truly has a cardiac disease. Gas exchange is also very interesting to assess the cause of an exertional dyspnea, and I won't go into detail, but we have a lot of criteria allowing us to separate when the patient complains of exertional dyspnea, if the dyspnea is due to heart failure or if it is due to pulmonary disease. I have to say that in real life it's more complicated because some patients have both disease. In severe pulmonary disease, you can have pulmonary hypertension and right ventricular failure, and also patients with severe pulmonary disease are often deconditioned. So it's not always as easy as shown in the books. Also, for example, exercise test is interesting to assess the heart rate response. For example, in a patient on beta blockade, you can assess, you can show an insufficient beta blockade, for example. On the other side, you can say that the patient has a chronotropic incompetence when heart rate does not increase very, very much. But it's more difficult to rely the chronotropic incompetence to the exercise intolerance. Are we sure that it is because of chronotropic incompetence that the patient is limited during exercise? For example, in this patient, you see there is a chronotropic incompetence at the beginning of exercise, the first 2 minutes, and then after heart rate increase in red. What you can see here, you have a sudden increase, a rapid, very early, severe hyperventilation at the beginning of exercise, that decrease after. This is typical of chronotropic incompetence because at the beginning of exercise, you have an increase in venous return to the lung. The patient suffocates, and after heart rate increase, and cardiac output can increase. And this is typical. When you have this kind of profile, you can be sure that chronotropic incompetence plays a role in the exercise intolerance. On the other side, you have a patient here with a clear chronotropic incompetence, but he has the same peak VO2 than the previous patient. And finally, some authors, especially in Italy, say that exercise testing with gas exchange is very interesting to detect myocardial ischemia. They assess the slope of the increase in VO2, and they say there is a change in the slope. At this time, you have ischemia leading to a reduction in cardiac output in exercise. and a reduction in VO2. They also assess, as I will explain to you later, the oxygen pulse, which flattens, and this is suggestive of ischemia. I have to say that in my experience, I think that this occurs only in case of very severe cardiac ischemia, and the simple EKG is, I think, most sensitive to detect ischemia. So finally, what are the other parameters you have to know when you see a report of CPX besides VO2 max and ventilatory threshold? All these parameters are interesting. For example, the oxygen uptake versus workload response. When you are a normal subject, you increase oxygen uptake by 10 ml of VO2 per watt. That's to say, if you, for example, you exercise on 100 watt, you had to increase VO2 by 1,000, okay? And the slope is here. Oops, sorry, it's here. And if you have heart failure, this slope is very much decreased. So this means that you cannot rely on the watt to assess the VO2 in patients with heart failure because the slope is decreased. In normal subject, you can assess the VO2, for example, here from work rate. In patients with heart failure, you have to measure VO2 because the slope is not the same. Another parameter you have to know, because it's now very popular in the heart failure field, is what we call the ventilation to VCO2 slope. In practice, it reflects the amount of ventilation needed to reject carbon dioxide. You and us, we have to ventilate about 30 liters per minute of ventilation for expiring 1 liter of CO2. So the slope is about 25 to 30. And for example, if you assess patients with heart failure, you can see that in severe heart failure, this slope is much steeper. That's to say, to expire 1 liter of CO2, you have to ventilate not 25, but sometimes 60 liters per minute. And this participates in the impression of dyspnea. I won't have time to explain the cause because it's very complex and we don't know exactly what is the meaning of this. They have a lot of parameters here. What is important to know is that these parameters has a very high prognostic value and now seems to be superior to peak VO2 to assess the prognosis of patients with severe heart failure. Also, you can see, for example, when you perform exercise test, this kind of pattern, which is called periodic breathing. You see, the patient do not feel anything, but you see that this ventilation is very erratic. It's a kind of chain stop during the day, and most of these patients have central apnea, and this is one of the most severe prognostic factor in heart failure. When you have this kind of ventilation, you see that the patient has a very poor prognosis. For years, we know that the response in blood pressure is very interesting, and when you don't have an increase in blood pressure, you may suspect a poor cardiac response, despite a preserved VO2. For example, if you have an athlete and you have a VO2 of 80, you can have a severe myocardial infarction. You will decrease VO2 from 80 to 40, which is correct, but blood pressure won't increase. And if you have no increase in blood pressure, you may suspect that the patient has severe heart failure. And finally, another interesting parameter is the oxygen pulse. The oxygen pulse is the ratio of VO2 by heart rate. So it's the product of cardiac output, AVO2 difference, divided by heart rate. And in fact, it's the product of stroke volume by AVO2 difference. It's the pulse of oxygen at every beat. So it reflects the forward ejected blood flow per beat. So it is decreased in heart failure. It is decreased in regurgitation because blood flow goes in the wrong direction. It is preserved in pulmonary disease, and it is also dependent on heart rate. And for example, you can see here a normal two response. For example, a normal response of the heart rate in a normal subject, and the pathologic response in a patient with heart failure, you have a plateauing or a decrease in oxygen pulse, which is very pathologic because it's the product of stroke volume by oxygen arteriovenous oxygen difference. Oxygen arteriovenous difference increase, so this means stroke volume decrease. Okay, this is the same mitral stenosis. I will skip on this. Okay, so in summary, the use of all the CPX parameters during exercise is very important for the patient. This slide showed you the major indication. You can see that there are a lot of indication, really a lot of indication of gas exchange. I would say only hypertension of detection of ischemia. For this, you don't need gas exchange. And finally, The last minute, I will speak about the prognostic value of this test. This is very important. Peak VO2 is a very important prognostic value in all disease, in normal subject, but also in patients with heart failure, in patients prior to surgery, now in patients with pulmonary hypertension. Pneumologists do this kind of test to assess outcome. We know that beta blockers improve outcome without altering peak VO2. So when you have a beta blocker, you shift the curve of the prognosis, and you have only to remember that now, when you have a patient not on beta blockers, a peak VO2 less than 14 suggests an indication of heart transplantation. But once the patient is treated on beta blocker, you have to decrease this threshold, and it's only when it is less than 11 of 12 then you can suggest a cardiac transplantation. And finally, you can associate a lot of parameters. For example, in this study, very large study, 600 patients published this month in this journal in the United States, you saw the prognostic response when you combine the VE to V2 slope and the response in blood pressure, and you can have quartiles, and you can derive a lot of algorithms. I have about 10 algorithms in the literature. I won't skip on this. And finally, for cardiac rehabilitation, I think it's more interesting to prescribe cardiac rehabilitation based on the metabolic threshold than on heart rate, for example, made on the Carbonen formula. In general, people train the patient based on the formula. This formula was made in only 8 subjects when you look at the Princeps publication, which is very, very strong. So this is my last slide. In conclusion, cardiopulmonary exercise testing allows assessing diagnosis issues. You can see it's very important for the cardiologist. It can be used in all exercise tests except ischemia detection or blood pressure response, where it has no additional value. It has a major prognostic value in heart failure or pulmonary hypertension, and it is also a value for exercise preparation in patient, in normal subject, or in sports cardiology. Thank you.